Hello, good evening everyone. Today we're gonna discuss how to deal with ventilator crisis. No, we're not talking about the real situation ventilator crisis that happens due to rapid upsurge of COVID viruses. So there is actually really shortage of ventilators and that the government has to deal with. We will be discussing about the actual ventilator crisis that happens when our patient is on the ventilator. What happens at that time and how to deal with it. In the very beginning, I must tell you about a myth. Every doctor, medical officers, they think in their mind somewhere the ventilator company, they have put the alarm in the ventilator to annoy us, to irritate us, to make us wake up in the middle of the night. I will tell you, it's not the truth. It's a myth. The truth is, the alarm is there for a purpose. And because it is there for a purpose, never ignore it, never mute it. However, you can do silencing. And how to do silencing? It is only conditional. Whenever you are silencing the alarm, that means we have come to know what the problem of the alarm and we have in your mind how to deal with it, then only you can silence the alarm. But never ignore or mute the alarm. Correct? So now all of us, we are very conversant with Mahatma Gandhi, and he exemplified the three monkeys. I'll not hear anything bad, I'll not see anything bad, I'll not say anything bad. In real life, we may not apply it very too often, but while in the ICU, we apply it quite often. We do not hear the alarm. If you hear by mistake, do not go and see the alarm. Even if you hear and see, do not say anything about it or do anything about it. So during the course of our discussion today, we'll try to see how we can change this notion and how to correctly deal with a ventilator alarm crisis. So now, telling about crisis, before dealing with any crisis, we have to think in mind we are dealing with human life. We are dealing with a patient. We are not dealing with machine. So whenever there is a crisis, whenever there is a problem, first come and look at the patient. Listen to the patient. Look at the things that are coming from the patient's body, the pulse oximeter, the ETCO2. Do a AVG and see, order and chest x-ray, then go and look at the ventilator. I have seen most of the time, doctors come in the ventilator, this, that. No, don't do that. First look at the patient, feel the patient, listen to the patient, look at the parameters, then go to the ventilator. So there are two kinds of ventilator crisis. One happens just after intubation. What can happen just after intubation? Now remember, when you are intubating a patient, what happens before intubation, patient is extremely tachycardic. Why? Because there is a sympathetic surge in the patient. So patient tried to save his life. In that process, he vigorously breathes. There is sympathetic actions. There is compensatory mechanism working in the body. Because of vigorous breathing, the diaphragm actually go very down. This patient is breathing like this. And because of that, there is a huge negative intrathoracic pressure, and that actually maintains the right ventricular preload. So what happens when we intubate the patient, we give some sedatives, we give some paralytics, and suddenly we blunt that response. On top of that, we are ambuing the patient vigorously. The 2-liter bag of ambu, we are putting all the volume to the lungs. So we are creating a positive pressure inside. So at the beginning, there is huge negative pressure that has been blunted. On top of that, we are putting very high positive pressure. So all these things add up, and patient, the RV preload actually decreases, and there can be hypotension and pulseless electrical activity leading to cardiac arrest. So you have to be very careful about it. How to deal with it? One thing is you can preload the patient adequately before we are intubating the patient. Second thing, do not compress the amoebic too vigorously. We need only 500 ml. So 1/3 or 1/4 compression is enough. And always keep an adrenaline series standby if something untoward happens just after intubation. So these things you have to be very careful. And just after intubation, what can happen? There can be endobronchial intubation. There can be catastrophic life-threatening esophageal intubation if it is caused unrecognized. So you have to be very, very careful about it. And there will be some problem that can happen there is some problem that happens just after intubation, and there will be problem that will be happening when the patient is on ventilator. For example, patient can have a high airway pressure, low airway pressure, low ambient ventilation, high ambient ventilation, apnea problem with ventilator like ventilated associated pneumonia, barotrauma, volutrauma, all these things can happen. So we have to continuously looking after the patient throughout the time when the patient is on the ventilator. Now, what are the minimum alarm that is needed to be set in the patient in different modes of ventilation? So if the patient is in volume control modes of ventilation, the minimum alarm that is to be set is the pressure alarm. It is very common sense because we have volume constant, what is called volume control ventilation. The volume is constant. So the alarm that you need is the pressure alarm. Similarly, in pressure control ventilation, because the pressure is constant, the alarm that we will need is the volume alarm. In a pressure supported ventilation, because we want the patient to be spontaneously breathing, so we need an apnea alarm. We need to know when the patient stops breathing, so the ventilator backs up. So these are the minimum alarm. So if they ask you, you don't have to set 2 alarm, 3 alarm, 4 alarm. You need to set only 1 alarm. So these are the alarms that you need to put in your patients. Now, in a ventilator crisis, there can be 2 things. So as you already discussed, there will be something that will come with alarm. You can recognize it. But as a clinician, you have to keep in your mind, there will be some problem which will not have an alarm. For example, if we put the patient on a ventilator and immediately in the post-op period, post-ventilatory period, patient is having hypotension. Now there is no alarm for hypotension. You have to go and check it. And the hypertension can be because of autopsy. Then you have to deal with it. So there will be some problem which will not have an alarm. Or the patient's work of breathing has increased a lot. Patient is tachypneic, tachycardic. You can have alarm for the respiratory rate, for the heart. But usually if it is not there, you cannot recognize it. So you have to go and look for it. What is the problem? Why is the patient work of breathing has increased suddenly? Patient is using all the accessory muscles of the body. We don't want it. We want the patient to be settled on the ventilator. But it's not happening. Why? So these are the problems that do not give you an alarm. So with our experience, we have to see this. We have to appreciate all these things. Of course, if there is alarm, we have peak pressure alarm, we have low tidal volume alarm, low maintenance alarm, alarm for low peak pressure, apnea, all these things are there. Alarm is there, but there is certain thing without alarm. That we have to be very, very careful. Now coming to troubleshooting. The one troubleshooting that we all have to learn, and 80% of problem will be solved in the ICU, that is the peak airway pressure alarm. All of us, you have to know this. The peak airway pressure alarm and how to troubleshoot it, how to fix it. So before discussing about the peak airway pressure alarm, we will discuss about the airway. So if we consider the human respiratory system, it is comprised of 2 things, one cylindrical structure and one globular structure. Correct? So from physics class, if you can recall, in ohmic conductor, in a cylindrical wire-like structure, the potential difference between the 2 ends is directly proportional to the current flowing through it into resistance. The same will apply here. The pressure difference between the beginning of the airway to the end of the airway, that is called the trans-airway pressure, will be proportional to the air flowing through it into the resistance. Now in a cylindrical structure, when something flows, it has to overcome a resistance because it cannot expand. But in a globular structure, it will expand. So all the resistance will be dissipated. Now what is important for us is the elasticity. It can expand or it cannot expand. So here the concept of compliance comes. change in volume or change in pressure. So if we just think about it, so the peak airway pressure will be equal to pressure due to resistance, the upper airway, and pressure due to the compliance, the globular structure of the lungs or alveoli and everything. So pressure due to resistance is equal to resistance into flow. Pressure due to compliance is equal to tidal volume divided by compliance. Of course, you have the peep also, plus peep. So this is called the equation of motion. The peak airway pressure is equal to resistance into flow plus tidal volume by compliance plus peep. Now from this equation you can find out that the peak airway pressure is actually directly proportional to the resistance of the airway, directly proportional to the flow, directly proportional to the tidal volume, inversely proportional to the compliance, and directly proportional to the peep. Now peep has a very ambiguous kind of relationship with the peak airway pressure that we will discuss in our AIDS lecture, but for the time being, these are the things the peak airway pressure depends. Now, if you have a peak airway pressure alarm, high peak airway pressure alarm, so the very first thing you can have is you can have a high resistance. As you have seen, the resistance is directly proportional to the peak airway pressure. So we can have a high peak airway pressure due to resistance problem. Resistance of the airway, the cylindrical structure. According to Poiseuille's formula, which resistance is equal to 8 NL by R to the power 4. So resistance is directly proportional to the viscosity, to the length, and inversely to the fourth power of the radius. Now in almost all our cases, viscosity and length does not play a significant role, but radius. So if you choose a wrong size tube, what will happen is it will increase the resistance fourfold higher. So it is very prominent, very eminent to choose a proper size tube. If you choose a wrong size tube and on top of that there is clot, secretion, patient bites, kinks, then the airway pressure will increase tremendously. So it's very important to choose a correct size tube. If you have chosen a correct size tube, then other reason for increased resistance will be patient can bite, tube can kink, there will be clot, secretion, bronchospasm, everything. It can increase the airway pressure tremendously. Second, compliance. So the compliance is actually inversely proportional. When the compliance decreases, the resistance increases. From the equation of motion we have seen. Compliance decreases means the lung has become stiff. It is not expanding properly. What are the differential diagnoses? Pneumothorax, the life-threatening one. Pulmonary edema, can have a massive pleural effusion. Patient can have ARDS, collapse consolidation, autopeep, abdominal distension, anything that compromises the compliance of the lung, it will increase the peak airway pressure. So we have a resistance problem, we have a compliance problem. Of course, it is directly proportional to the tidal volume, to the flow, to the peep. But when you set a patient on a ventilator, these things are constant. So these things cannot increase the peak airway pressure suddenly. However, they can make it look bigger, the peak airway pressure. So do not temper on it in the beginning. You can do as a temporizing measure to keep the peak airway pressure a little bit low, but this is not a solution. Decreasing flow, decreasing tidal volume may not be the solution always. So we have to find out what is the resistance problem, what is the compliance problem of my patient. Now we have a huge list of differential diagnosis. Resistance problem, compliance problem. How we can differentiate these two things so that we have few differential that we can deal with it. So then we have to apply what we call as a inspiratory pause or T pause or T plat. So if you put inspiratory pause time in the ventilator, it will be there in all the ventilator. What happens is you are actually stopping the flow for a certain period of time inside the lung. So because you are stopping the flow for a certain period of time, the pressure that is there inside the lung is actually the plateau pressure. Correct? There is no flow. There is no resistive force or pressure. So that is the plateau pressure. So if we apply a P pause, it will differentiate the two pressures that we have discussed earlier, the pressure due to resistance and pressure due to compliance. Both will be disconnected. So now we can find out whether I have a resistance problem only or compliance problem only. So if the resistance is high and compliance is low. So the trans airway pressure, the driving pressure, difference between the peak airway pressure and the plateau pressure is more than 10 centimeter water, then it is a upper airway problem or a resistance problem. So your differential becomes very narrow. Patient can have a small size tube, kink, clot, secretion, bite, bronchospasm. If the P plate is very high, more than 30 centimeter water, then there is a compliance problem. And we have your differential diagnosis like auto peep, bronchospasm, auto peep, pneumothorax, pulmonary edema, ARDS, color consolidation, abdominal distance, and everything that can happen. So now, because you are applying inspiratory pause, you can see we have segregated the resistance problem and the compliance problem into two different parts. So our differential becomes very, very minimum. So now we can deal with each problem effectively. Correct? Now, coming to the next alarm that we have to deal with. Now before that, so this is the picture of the pressure time curve. When you apply inspiratory pause, what happens? You can see there is a peak airway pressure, there is a pause, then the plateau is coming. So if the difference between the P plat and the P peak is called the trans airway pressure, and it has to be less than 10 centimeter water, and the P plat should be less than 30 centimeter water. Sometimes you can have both of these things high. The driving trans airway pressure is high, at the same time the plateau pressure is also high. In an ARDS patient, it can happen. In an ARDS patient, you are dealing with a high plateau pressure, and top of that the tube is blocked. So now there is both the pressure will be high. It's not that either P plat will be high or the driving pressure will be high. Both can become high, so we have to deal with it accordingly. Correct? So now let's discuss about the low minute ventilation alarm or the low pressure alarm. So we have set a pressure, total volume. So if it is coming low in the ventilator alarm, that means the pressure is leaking from somewhere, the volume is leaking from somewhere. So find out, is there any circuit disconnection? Is there any loose connection? Is there any cough leak? All these things you have to find out, whether you have set the flow inadequately. If these things are there, water traps there, then the solution you have to choose accordingly. Tighten the connection, reconnect the ventilator, ensure the cuff is okay, inflate the cuff volume. If it is ruptured, change the ET tube. The ET tube can be displaced proximally, so you have to replace it in a proper position. So all these things you have to take care. Then there will be what I call as a high minute ventilation alarm. What do you mean by high minute ventilation alarm? So high minute ventilation alarm means patient is breathing at a very high rate than you have set. So first two things you have to rule out is whether there is any water trap or not. If there is any water trap, it will cause auto trigger and patient will be hyperventilating. Second thing you have to see whether whenever there is an high minute ventilation alarm, the trigger that you have set, whether the trigger has been set inappropriately, sensitivity is very low. So any trivial change in the pressure is actually giving a breath. So if these two things are settled, then you have to find out why a patient can have otherwise high minute ventilation. For example, patient in sepsis can have high minute ventilation demand. Patient hypoxia, anxiety, pain, acidosis, all these things can have a high minute ventilation demand. So you have to be very careful about it and deal with each problem accordingly. Correct? Then you have apnea alarm. Of course, apnea alarm means if the patient is not breathing, then the ventilator will back up with a time ventilation or control ventilation. So it has to be set appropriately, not too high, not too long. Otherwise, patient will have apneic episodes and patient can have cardiac arrest. So the apnea alarm has to be set accordingly, appropriately, at least in pressure support ventilation, where we want the patient to be conscious and breathing on its own. Right. So now to summarize all our cases, so if a patient having acute respiratory deterioration, so if a patient is actually having acute respiratory deterioration, how to approach? The first thing is check for the P peak. If the P peak is raised or the peak airway pressure is raised, so there can be three probability: if it is raised, if it is low, or there is no change. If the peak airway pressure is low actually, then there is leak in the circuit. So we have to deal with the leak as we have discussed before. If there is no change in the peak airway pressure, but the patient's respiratory condition has deteriorated, then there is some other problem that may not be solely responsible for these things. For example, pulmonary embolism. For example, systemic problems like new onset infection, sepsis can happen to these patients, and that has actually caused the respiratory deterioration, right? However, if the peak pressure is increased, the next step you do is check the P plat pressure by putting inspiratory pause. If the P plat is also increased, so the P peak is increased, P plat is increased, so we are dealing with the compliance problem, provided the transfer pressure is less than 10. The P peak is increased and P plat is normal, then we are dealing with the resistance problem. So whenever we have these things, we have differentials of the resistance problem, differential of the compliance problem. In that way we deal with it, right? So whenever you go to a patient to troubleshoot an alarm, so your prescription should be like this: I have troubleshooted the alarm. Whether there is a resistance problem, write it. Whether there is a compliance problem, write it. And how you have dealt with it, that was write it. That will be your prescription. For example, if it is complex problem, order a chest X-ray. If you are suspecting pulmonary edema, anti-inflammatory, ECG, cardiac enzymes, all these things, X-ray. If you are suspecting massive pleural effusion, do a chest X-ray. If you are suspecting ARDS, collapse consolidation, do a X-ray, CT scan. All these things you have to think in your mind. That's how you deal with it. Then something I call that manually applying a P pause or inspiratory pause. How to manually apply it? So whenever you are in doubt, you do not have much idea about the ventilators and there is no enough time to do all these things, just disconnect the ventilator. Just disconnect the ventilator and ambu the patient. When you do that, if the patient improves, then you come to know that the ventilator was the problem. Because when you ambu the patient, you bypass the ventilator of the circuit. Correct? And if the patient improves actually, then you found out that actually the ventilator was in problem. Even if patient doesn't improve, the ventilator is not at fault, or you can find two things here. If you use a suction catheter, orange variety, and you can negotiate the suction catheter through the ET tube is not blocked. Secondly, it can suction out any material present inside. And even if the upper airway problem is not there, when you ambu the patient, you can measure the compliance of the lung with your experience, whether it is easy to ventilate or difficult to ventilate. So the thing that we are getting by putting inspiratory pause, that is whether it is a resistance problem or a compliance problem, the same thing you can achieve here by ambuing the patient, putting a suction catheter inside the tube. We can find out whether it is a resistance problem or a compliance problem, then you have to deal accordingly. Another method is the very simple, so DOPE technique. So whenever there is a problem, respiratory deterioration or high peak airway pressure, this four thing has to be done sequentially. D for displacement or disconnection, displacement of the ET tube, disconnection of the ventilator circuits and all. O for obstruction, kink, white clot, secretion, tube blocks. P for pneumothorax, compliance problem. Or E for equipment failure, the ventilator has failed completely. So this is a very simplistic technique how to deal with in the beginning, but difference is actually larger, so we have to keep on thinking what has happened to my patient and all. So this is how we deal with the peak airway pressure alarm. Now my question is, read this case and there is a peak airway pressure alarm and we have few options. What is the correct option? Either you call the sister and tell him to silence the alarm, you go yourself and silence the alarm, or you thought let it ring, I will not do anything, or you sedate the patient, or you give vacurinium. None of these answers are correct. The correct approach, as I have told you earlier, go to the patient, look, listen and feel, check the parameters, go to the ventilator, check the airway pressure, divide the problem into resistance or compliance problem or other systemic problem like pulmonary embolism or systemic sepsis, then deal accordingly with it. You know what is the difference between knowledge and wisdom? Knowledge and wisdom are not same. Many people think knowledge and wisdom are same. but they are not. For example, cigarette smoking is bad. This is knowledge. Everybody knows it. But very few people are able to apply it in their life. Those people who can apply it in their life, they have actual wisdom. So knowing certain things does not prove that you are endowed with wisdom. You may be knowledgeable. So all the discussion I have told you, it increases our knowledge only. When we apply it in our patient, in the ICU, in the OT, then only we will have wisdom. And when we have wisdom, and then wisdom actually sets us free. Also correct. So always try to apply these things in your patient, in the OT, in the ICU. Then that is the success of life. Thank you very much.